Hi there, I'm Caleb Weiss. I'm a assistant professor of clinical psychiatry within the psychiatry and psychology department at UICOMP. I am a physician by training and do most of my teaching through clinical work with residents and medical students. I teach M1 students during their Block 6 lecture series and do a handful of the psychiatric lectures that they do during that block. I also do lectures for psychopharmacology and psychosis for the M3 and M4 students. In order to promote critical thinking and problem solving with my learners, a lot of the times it's within throwing them within clinical settings, whether it be in the inpatient unit, in the outpatient unit. It's a lot of times it's with just looking at presenting the idea of doing the clinical interviews with patients and trying to promote looking at them as a whole person rather than just within just psychiatric terms as well, just because so that we are making sure we're not just missing out on other physical health issues that could be contributing to underlying psychiatric problems as well, and using that framework in order to how to better approach their treatment, both in the hospital and looking for discharge as well as in the outpatient setting, so that we can hopefully treat them as a whole person that will then influence their psychiatric care. A typical scenario where I'll help guide a learner, whether it be a medical student or a resident, in using their critical thinking is usually within patient encounters, whether it be on the inpatient side of things or outpatient. Usually in that situation, I'm usually teaching them how you chart review a person in order to kind of look at the scenario of the information that's presented to you, both in the current encounter as well as historically within chart review, and being able to kind of look through things in a way of how their differential would look just off the information that's given to us by other providers, and before even diving into the actual clinical interview. And then a lot of times it's then bringing them on the inpatient side, usually is helping guide the clinical interview or modeling how that clinical interview should go before making decisions based off of the information we gathered, how to go about their treatment. In the outpatient setting, it's usually through supervision and then providing feedback to them after the resident has interviewed the patient in order to go through what their differential is, what they think is the most likely diagnosis, and the best way to approach from usually a medication standpoint, but also integrating their ideas about therapy into it too as well. So a lot of times when approaching education with whether it be with med students ranging from the M1 years all the way up to residents within the PGY 4 year, at least within the psychiatry department, I actually assume that everyone's kind of at the same level and go and approach it from starting low to see kind of where people, where the student, where the learner in general is at, in order to, and then if they are able to, with questions I'm asking, whether it's presenting clinical scenarios to them or just even asking kind of basic questions about whether it be psychopharmacology or diagnostic standards, kind of escalating maybe complexity or how in depth I go with that learner. If they're able to keep up, then I will keep going up higher in terms of the the performance within that. If there's someone who's kind of more on a not knowing as much, then I'll keep it to their level, keeping it bare minimum of what they need to know, but also try to push them to see if they will either come back to me on a later day with like reading up on the topic that we were previously talking about. I also, within some of the lectures I do, because I recognize that not every, though psychiatry is a core rotation for medical student learners, I recognize that it may not be as big of an interest as, my own biased view. And so I at least try in some ways with figuring out what a med student is interested in most. And so I actually will then sometimes gear the learning aspects that I try to do about a topic towards what they're actually interested into. So, say someone who's more interested in either internal medicine or family medicine, I'll actually gear things presented in a way that a PCP would like, a primary care doctor would like to know, because they'll in the future be seeing more psychiatric patients than even the psychiatrists, because they're PCPs and they see a lot of patients. So I tend to try to, at least if I can, personalize with the students and even the residents as well to what I know their best in, or what their favorite interests are, in order to kind of drive home the points, because then that'll actually help encode the information better, actually, if they have points that they actually either remember better, or that it aligns with their interests.